often asked, what is this neuromodulation thing? And I'm asked that as much by fellow doctors as I am by patients. And indeed, the term neuromodulation, it's not really self-evident exactly what that is. It sounds a little bit like something out of a science fiction movie, like The Matrix or something, for example. So neuromodulation, quite simply, is altering the nervous system in order to optimise health or to reduce disease. So it can apply to an electrical way of changing the nervous system. It can apply to a chemical way to changing the nervous system. So a very common example that I'm sure we're all familiar with would be the cochlear implant, which is used to treat patients who've got deafness. So that is neuromodulation. That is modulating one particular nerve, the auditory nerve, in order to help facilitate improved hearing. That is, reduce the disease of deafness. So that's a common example of something that might be experienced. Now, in terms of pain medicine, when we talk about neuromodulation, we're typically talking about particular advanced therapies that can be deployed in a pain clinic. And by that, we're typically referring to something called spinal cord stimulation. Now, that may be something that you've heard before. You may have had a friend or family member who's had a trial of that therapy, or actually, in fact, received that therapy. And often have patients either gush very enthusiastically to me because they know somebody whose life has been fantastic as a result, or they say, oh, I don't think I really want to trial that. I heard of somebody who didn't get a great result from that. And obviously, personal stories ring true to patients. They're trying to understand sometimes the minefield of medical practice, but perhaps we can put into some perspective to give information out there about when something like spinal cord stimulation is effective and when it is ineffective. So typically, a person who's got what we call nerve pain or neuropathic pain, and that nerve pain is persistent, and that nerve pain is not immediately correctable. So a person could, for example, have a pinched nerve in their spine because they've got a little bone spur that's pressing on the nerve, and now they've got sciatica going down their leg and into their toes. Now, if that can be documented on an MRI scan, that there is compression of the nerve and the type of symptoms they are matched to the type of symptoms they should have if the nerve's being compressed, then the most effective thing for them is going to be something called a foraminotomy, where the person will actually have a little bit of that bone spur removed by a surgeon and the pressure on the nerve is released, and therefore there is no more pain. So you want to make sure that there's not a direct cure or surgical treatment available for that particular nerve pain. Then the persons want to have undergone appropriate conservative management for that nerve pain. So we have in pain clinics treatments related to medications. We may have treatments related to simple injection procedures or other procedures where we can pulse heat nerves, for example. So a bunch of things that can be done that can reasonably control neuropathic pain and means that the patient isn't a candidate for an advanced pain therapy such as spinal cord stimulation. But at the end of the day, for every 100 people that I see in a pain clinic that come through my door, we're probably going to see 2 patients or so who have got this condition of refractory, meaning persistent nerve pain, persistent neuropathic pain. And where that is in a large enough area that it can be relatively blocked by the treatment spinal cord stimulation, which is a form of neuromodulation, then that's something the patient can be considered for. So there's our first criteria, that the patient has refractory neuropathic pain. The pain is in a particular pattern where a spinal cord stimulator has a chance at reducing it. And then we want, in addition, to be no what we call contraindication for the person to have a trial of the therapy. And by contraindication, we mean they don't have a bleeding disorder or they don't have an obstruction in the epidural space where the little lead is going to go. So particular reasons why it wouldn't be sensible or safe to actually have that procedure. But the person having had clearance for that, and we know that this person doesn't have other issues that we think might reduce the chance of success. So people with a lot of anxiety, people with a lot of untreated depression, people who are still on large doses of opioid analgesics. These are some of the things that we know mean that the therapy doesn't work as well as if they're not present. So we would want to treat those things first to optimise the outcome if the patient was going forward with a trial of spinal cord stimulation. So a spinal cord stimulator is a tiny little electrode. It's a bit like hollow fishing line, if you like, but with the small electrical contacts on it. And it connects to a small battery, if you like, a little pacemaker for nerves, if you want to think of it like that. And that generally sits in the fatty part of the love handle, for example, where most people can have it hidden away without it being obvious. So it's underneath the skin as an implant. Now what we want to do is we want to find out if this is something that's going to work for an individual in terms of reducing their pain. And so they'll have a trial of the therapy first before they actually have it as a permanent implant. And that trial is done just through a needle, and the electrode is put into position, generally performed under a little bit of sedation and X-ray guidance by using a mobile X-ray machine for the physician. And then the small pulse generator can be taped to the skin, and the patient can take it home for a week or 2 weeks, for example. And we want the patient to go back into the type of life they were previously leading, so return to some normal activities, if you like, and we see if their pain is reasonably controlled. And by reasonably controlled, we would like to say pain-free, but we don't typically see pain-free as an outcome from an application during a trial phase or a permanent implant phase of a spinal cord stimulator. We can see success as being a reduction in pain by a half or 3/4 or 4/5 or some significant chunk, but rarely do we see complete elimination of the pain. But if we do see a response, that indicates then that the patient's nervous system is responsive to this type of therapy, and the patient can then go on to have the lead implanted, where it's sutured in place underneath the skin, connected to the little battery, and again that is sutured into place. And then the patient either goes home the same day or goes home the next day, and they'll have a little remote control that they can turn the device on and off and modify some of the functions of the device so that they can have a reduction in pain. There are a couple of different ways, so each device typically has a few different waveforms in it. Those waveforms can be adapted and adjusted to the particulars of an individual patient, and it may be one where they don't feel any tingling, buzzing or throbbing. It simply blocks a part of the incoming pain. And the other technique is where the patient can feel a very light, gentle tingling, buzzing or throbbing sensation over their pain area, and that's part of the mechanism via which the pain is then reduced. So this is something that is then used rather than large amounts of opioid analgesics, used rather than taking 3 or 4 different nerve tablets at once to reduce pain, and it can be a very effective treatment. It doesn't work for everyone long term. We'll typically see somewhere between 10 to 20% of patients, their pain will somehow come back again. And obviously, like any medical endeavour, there are the potential for complications associated with it. And we typically see complication rates of 5 to 15% associated with this therapy. Like anything in medicine, the more you do of it, generally the better you get at it. And so it is ideal, if you're having a discussion on this, to try and ensure that you're seeing somebody who's doing a reasonably large volume of these. So we have what we call centres of excellence around the world, where high volumes of these are performed by very experienced practitioners in the field. And that's probably going to be better than somebody that might do 2 or 3 of these a year, for example, and may not be experienced as somebody who's doing 30 a year or more than that. So that's just a brief intro in terms of what is spinal cord stimulation. There are other neuromodulatory techniques as well. It's becoming more common, and certainly if I look at the last 24 years of my involvement in this field, we've seen a dramatic increase in the effectiveness, what we call the efficacy, but essentially that's meaning the effectiveness of this treatment. Now, what I want to specify is the whole time I've been talking about this neuropathic pain, this nerve pain. So those pains that are not related to that, those pains that might be coming from knee arthritis or hip bursitis or tendon damage in the foot or arthritis in the elbow, these are not neuropathic pains. And these pains do not respond well to spinal cord stimulation. Other techniques need to be applied here. So it's very important that you see somebody experienced in this field who can diagnose the type of pain you have, apply the conservative therapy, and if at the end of the day you're a suitable candidate, either able to treat you in that regard or refer you on to an experienced neuromodulatory practitioner who can perform the procedure for you and then have ongoing care as part of that package. So a little bit more information there on spinal cord stimulation.